Join me on a journey back in time as we explore and savor the world of medical antiquity. Historical evolution of angina, medical history.
The term angina originates from the Greek gamma chi omega, meaning to constrict. Hippocrates described it as Synanche, referring to diseases of the throat and larynx causing difficulty in breathing and a constricting feeling. He distinguished several forms based on the inflammation's location and severity. The name Synanche might come from patients protruding their tongue like dogs. Radiates debated this origin. Hippocrates also identified a milder form called Synanche. Later, terminology became complex with terms like Synanche for laryngeal issues and Synanche. Galen simplified matters, calling all throat and larynx diseases impeding breathing Synanche. Arabic medicine contributed terms like Cynanche, today excluding angina pectoris. Angina refers to inflammatory diseases of the swallowing and breathing passages. Even with a narrow definition, many diseases are called angina: diphtheritic, catarrhal, syphilitic, etc. Lacunar angina, once called follicular, is localized in the tonsil crypts or lacunae. Hence Wagner's preferred name. Lacunar angina is infectious, indicated by chills, high fever, and spleen enlargement. Its epidemic nature suggests contagion, though cold weather was once blamed. It often spreads in families and hospital wards. It must be distinguished from diphtheria, though they can coincide. Pure lacunar angina can still be contagious. Causative microbes are debated. Streptococci are often implicated. Cold is merely a predisposing factor. Pathologically, it involves inflammation of tonsil epithelium and adenoid tissue. Exudate fills lacunae, forming dirty white plugs that merge on the surface. It affects all ages, but is most common in young and middle-aged adults. Symptoms begin suddenly with violent chills and fever up to 40 C. Headache, back pain, vomiting, and prostration occur. Swallowing is difficult and painful. Submandibular lymph nodes swell. Concomitant stomatitis is common. The illness rarely lasts more than 3 to 4 days. Subjective symptoms fade first. A frequent complication is peritonsillar abscess. Diagnosis is visual, but bacteriology rules out diphtheria. For treatment, quinine hydrochloride is highly effective, often ending the illness in 24 to 36 hours. Bed rest, light food, and warm neck compresses are advised. Patients should be isolated due to the infectious nature. Angina pectoris, or chest angina, was first detailed by Heberden. It's a symptom complex, not a disease itself, often accompanying circulatory disorders. It must not be confused with cardiac asthma, which involves true dyspnea and congestion. Angina pectoris is characterized by paroxysmal pain originating in the heart and radiating along nerves. True shortness of breath is not obligatory. When present, it may be due to combined cardiac asthma or reflex from pain. Attacks are often triggered unexpectedly by physical exertion, cold, overeating, alcohol, or emotional agitation. The pain is severe, boring or burning, with a feeling of tightness behind the sternum, radiating to the back and shoulder blades. The attack forces the patient to stop. A sense of impending doom, pallor, and cold sweat are common. Movement worsens pain, so patients freeze. Pain often radiates down the left arm to the fourth and fifth fingers, causing numbness. Rarely, pain radiates to the right arm, neck, jaw, or abdomen, the latter called pseudogastralgic angina. Pulse may become rapid and tense or, less often, slow. Vasomotor angina involves vascular spasm triggered by cold. Knothnagle described vasomotor angina: stiffness, numbness, pallor, and coldness in extremities, especially after local cold exposure. Attacks last 15 to 30 minutes and are relieved by rubbing and warming. Similar mild attacks can occur with dyspepsia or gallstones. Etiology distinguishes true angina from organic heart disease and false angina from external causes. True angina has a grave prognosis and is rarely cured. True angina is linked to coronary artery sclerosis, aortic valve defects, aneurysms, or syphilitic lesions. Coarlasm or exhausted heart from strain or infection can also cause it. False angina includes toxic causes like smoking. Excessive smoking, strong tea, or coffee can induce attacks. Vasomotor and reflex angina from gastric or nervous disorders fall under false angina. A neuritic theory proposed nerve inflammation as a cause, but evidence was limited. Angina pectoris is more common in men and the elderly, linked to arteriosclerosis, obesity, and moderate lifestyle. Gout and heredity are factors. The paroxysmal radiating pain suggests a neuralgic origin in the cardiac nervous system. Heberden thought the essence was heart convulsions. Perry and Stokes believed it was sudden weakness of an already weak heart, leading to blood accumulation. Traub modified this to sudden ventricular overfilling and nerve compression. These theories fail because pulse and blood pressure often remain normal or even elevated during attacks. Romberg's view of it as cardiac plexus hyperesthesia was also insufficient. Ignoring anatomical coronary changes. Sclerosis of coronary arteries, especially at their origin, can critically narrow them. Complete blockage leads to fatal cardiac arrest, as in the sudden death of sculptor Thorwaldsen. Potain explained attacks by myocardial ischemia. Potain compared it to intermittent claudication in limbs. Narrowed coronaries can't supply the heart under exertion, causing ischemic pain and muscle weakness, however. This alone doesn't explain all cases. Severe angina can exist without significant coronary changes post-mortem, and sclerosis can exist without angina. Attacks often give way to cardiac asthma in later stages. Neusser and Pell added vascular spasm as a key factor. Vascular spasm enhances ischemia's effect. Pain may originate from vessel walls themselves, a colicky pain. Cessation of attacks in late stages may be due to myocardial scarring or rigid vessels preventing spasm. Pathogenesis of organic angina shares features with other forms. Vasomotor angina is pure reflex vascular spasm. Toxic angina in smokers likely involves coronary spasm. Rare cases from aortic pressure may also involve spasm. Pain radiation is explained by neural connections of the cardiac plexus to the arms, neck, and head. Why the left arm is more affected is unclear. Diagnosis is usually straightforward except for abdominal forms mimicking gastric issues. Careful examination for aortic disease signs is crucial. Angina must be distinguished from intercostal neuralgia and non-anginal cardiac pains common in neurasthenics. Vasomotor angina is identified by cold triggers and peripheral spasm. Prognosis of true angina is serious, with sudden death possible. False angina is often curable with proper regimen. Treatment has two goals: relieving the acute attack and preventing recurrences by managing the underlying condition. Patients must avoid triggers, exertion, cold, heavy meals, alcohol, tobacco, and stress. During an attack, rest is vital. Mild stimulants like valerian castoreum or ether can help. Skin irritants like mustard plasters are used. Some find relief with cold compresses or ice, others prefer warmth. For severe pain, morphine injections can be necessary, despite some doctors' fears. Inhalation of sulfuric or acetic ether can give quick relief. Amyl nitrite, causing vasodilation, was popular but unreliable and lowers blood pressure. Nitroglycerin is better for systematic use, reducing attack intensity. Sodium nitrite was also proposed but may decompose in the stomach. Electrization is risky due to potential fatal heart fibrillation. For long-term prevention, iodine preparations like sodium iodide or iodine are beneficial, possibly by reducing blood viscosity. Diuretin theobrominum salicylicum and thiacin natter, ESIT, also show good prophylactic results. Systematic gymnastics and massage can help in mild cases. The underlying heart disease must be managed in attack-free intervals. Lifestyle regulation is key. Diet should be light, easily digestible, in small portions. Constipation must be avoided. Alcohol and smoking are forbidden. A mild southern climate is preferable in winter. In summary, angina encompasses both throat infections and cardiac pain. Lacunar angina is a contagious tonsillitis treatable with quinine. Angina pectoris is a complex cardiac syndrome with pain radiating from the heart. Its true form is linked to coronary sclerosis and vascular spasm, carrying a serious prognosis. False forms have various external causes. Treatment involves acute pain relief with narcotics or vasodilators and long-term management of triggers and heart health. This historical text reveals the evolution of medical understanding from Hippocrates' observations to 19th century pathological theories, highlighting the enduring challenge of diagnosing and treating chest pain. The intricate descriptions of symptoms, pain pathways, and debated etiologies provide a fascinating glimpse into pre-modern cardiology, where clinical observation was paramount in unraveling the mystery of the heart's most alarming signal.
The exploration continues. Week by week, we will journey deeper into history together. Our path leads us through a grand archive of 16 volumes, each containing 700 pages of knowledge to be shared.